Very good morning, students. Today we will be discussing regarding inborn error of metabolism. Having studied the proteins or amino acid metabolism, carbohydrate, lipids, nucleic acid metabolism, I would like to go through only the inborn errors which are caused due to some error in this metabolism. Under this, we'll be studying about the background, the inborn error of metabolism of amino acids in this class, Phenylketonuria, Alcaptonuria, so Archibald Edward Gerard was an English physician who pioneered the field of inborn errors of metabolism. He coined the term IEM, otherwise the inborn error of metabolism. He also discovered Alcaptonuria, and we all know that there is a tetrad named after Gerard, that is Gerard's tetrad, which is important for your MCQs and Viva. We will be discussing it later. What are these inborn error of metabolism? What do you understand by the term inborn error? It is an inherited, because it is inborn. So it is inherited enzyme deficiency, which is caused by maybe a single gene defect resulting in disruption of normal body mechanism. So it is caused by a single gene defect resulting in disruption of normal body mechanism. Most are due to the defect in an enzyme, the transport protein, which results in a block in a metabolic pathway. Accumulation of toxic substrate before the block. Say a substrate is converted to a product. So if the required enzyme is deficit or absent, so what happens? The substrate will be accumulated. It will go on increasing in the blood. If it is soluble, it will get excreted in the urine. Some gets deposited in the tissues, connective tissues. So sometimes these substrates, they go in for an alternate pathway which can produce some toxic metabolites. So accumulation of this toxic substrate before the block, accumulation of intermediates from alternative metabolic pathways, or impaired formation of a product normally produced by the deficient enzyme, leading to defects in energy production and utilization. Now look at this. Oh, there's a shift. It's okay. The product should be here. Okay. Now, say this is a precursor A will form substrate B in the presence of the enzyme AB. So enzyme is present, so the precursor forms a substrate B. Now, this substrate B in the presence of the enzyme BC will form the end product C. When this enzyme BC is absent, or if it is deficit, so what happens? The substrate B will go on increasing, or it might go into an abnormal metabolic pathway to form a toxic metabolite, that is D. So in case of inborn errors, so the product cannot be formed, but the substrate will increase, or the substrate will go for an alternate pathway, that is, they might be toxic or they might get excreted in the urine. Disorders of protein metabolism. So whether it is protein metabolism, carbohydrate, lipids, then the mitochondrial disorders, paroxysmal disorders, all these are the major categories which all produce certain inborn errors. So protein metabolism will give rise to certain amino acidopathies, organic acidopathies, or urea cycle defects we will be studying today. Disorders of carbohydrate metabolism, that is carbohydrate intolerance disorders, your glycogen storage disorders, which are very, very important, disorders of gluconeogenesis and glycogenolysis. So there are some lysosomal storage disorders of fatty acid oxidation defects, mitochondrial disorders or paroxysmal disorders. All these will give rise to inborn errors. IEMs individually are rare, but collectively they are very common. The presentation can occur anytime, even in adulthood. The diagnosis is made based on this high index of suspicion. What is this high index of suspicion? It can be acute life-threatening illness, say encephalopathy, lethargy, irritability, which leads to coma, and further to the person might go into death. There might be vomiting, recurrent vomiting, respiratory distress, children with seizures or fits or convulsions, what we say, developmental delay, so the milestones will all be delayed, the IQ will be less, then the unusual odor of urine. I will be discussing about this again later. So how are these classified? So the disorders of amino acid metabolism can be phenylketonuria, very important for your exam, Alcaptonuria, homocystinuria. There are others, albinism, tyrosinemia, MSUDs, maple syrup urine disease. Now, disorders of carbohydrate, I told you about galactosemia, glycogen storage disorders. For porphyrin, acute intermittent porphyrias, which are again very, very important. All these are very important as a short note. Disorders of purine pyrimidine metabolism, I have explained this in my class, Lesch-Nyhan syndrome. Disorders of steroid metabolism, congenital adrenal hyperplasia. Mitochondrial disorders, Kearns-Sayre syndrome. Paroxysmal Zellweger's syndrome, lysosomes, it is lysosomal storage diseases. These are some of the disorders of the major metabolisms. Coming to phenylketonuria. So when we tell phenylketonuria, chunk the word, so it is from phenylalanine metabolism. So there is ketone bodies. Where is it present? It is excreted in urine. The ketones are excreted in urine. So from where they are obtained? They are from phenylalanine. Norwegian doctor Abjorn Folling discovered phenylpyrovica, which was later termed as phenylketonuria in 1934, upon discovering that 10 mentally retarded patients had phenylpyruvate in their urine. The disease was described as inborn error of metabolism. This was the first inborn error of metabolism proven to affect the mind. Both the parents here are carriers who are unaffected. Their offsprings, one is unaffected out of the 4 children. So one is unaffected, 2 are carriers, again unaffected, and 1 child is affected. So there is 1 in 4 chances of getting phenylketonuria. Phenylketonuria, otherwise PKU. It is due to deficiency of phenylalanine hydroxylase enzyme. Where do you come across this? This is the first step in the conversion of phenylalanine to tyrosine. So what is this phenylalanine? It is an aromatic amino acid. It is an essential amino acid. It is both glucogenic and ketogenic amino acid. So here this phenylalanine, when there is deficiency of phenylalanine hydroxylase, so what happens? Phenylalanine is not converted to tyrosine. So we say phenylalanine is an essential amino acid, whereas tyrosine is a non-essential amino acid because it can be synthesized from phenylalanine. This is an irreversible step. This is a very important step because it requires a molecular oxygen. It requires a molecular oxygen. It requires ferrocyanide. It requires NADPH or NADH. It also requires a cofactor, that is tetrahydrobiopterin. Tetrahydrobiopterin. It is a cofactor which is synthesized from GTP. So it is mainly used in hydroxylase reactions, especially in aromatic amino acids and also in nitric oxide, sorry. So now this reaction, that is phenylalanine conversion to tyrosine, requires phenylalanine hydroxylase. It requires a molecular oxygen. So it gets converted into by 2 steps. One is this molecular oxygen is converted or reduced to water, and 1 O is taken up to form water. The other one is taken up by tyrosine. At para position, it forms hydroxyphenylalanine, nothing but, or otherwise known as tyrosine. So from where do you get this H2? This is obtained or donated by tetrahydrobiopterin. This tetrahydrobiopterin is synthesized or regenerated from dihydrobiopterin. Now dihydrobiopterin by reductase. So this is NADH plus H dependent, NADH dependent reductase. So dihydrobiopterin is converted to tetrahydrobiopterin and NAD plus is formed. This can also be synthesized from dihydrobiopterin with NADPH plus H to form NADP. I repeat, phenylalanine hydroxylase, so it converts phenylalanine to tyrosine. So it requires molecular oxygen, ferrous ion, NADPH or NADH and tetrahydrobiopterin. So molecular oxygen, so one O is taken up by hydrogen to form water molecule, and the other O, the atom, is taken up by phenylalanine to form hydroxy, that is para hydroxy phenylalanine, so thereby forming tyrosine. So hydrogen is donated by tetrahydrobiopterin. This is regenerated with the help of dihydrobiopterin and NADH plus H. So remember, this is an irreversible step. This is a recessive condition. Incidence is 1 in 10,000 live births. Phenylketonuria, there are 5 types. One is type 1 is classical type of PKU, where there is phenyl hydroxylase is absent. Type 2 is persistent hyperphenylalaninnemia. Anemia means in the blood. So there is decrease in phenylalanine hydroxylase enzyme. So there is decreased synthesis of phenylalanine hydroxylase. In the class 1 type, the classical type, it was absent. Here it is deficit. Type 3 is transient mild hyperphenylalanemia. There is maturation delay of phenylalanine hydroxylase enzyme. Dihydropyridine reductase deficiency. So there is deficiency or absent of dihydropyridine. Phenylalanine cannot be converted to tyrosine, as I have explained already, because the enzyme phenylalanine hydroxylase is deficit. So what happens? There is increased phenylalanine in the blood. So there is hyperphenylalanemia. So phenylalanine accumulates and enters. So it goes for an alternate pathway. That is, even this is important for a short note. It comes as a short note. That is alternate or minor pathway of phenylalanine. So first you have to explain the phenylalanine hydroxylase deficiency. So how that step takes place. So when that enzyme is deficit, so what happens? It goes for this alternate pathway. So in the presence of transaminase, so this is a reversible step. So transamination reaction takes place here. So what happens? Alpha ketoglutarate forms glutamate, or glutamate forms alpha ketoglutarate, depending on the substrates present or the metabolites present. So phenylalanine is converted to phenyl pyruvate by transamination. Now phenyl pyruvate undergoes reduction, so with the help of NADH plus H to form phenyl lactate, which is excreted in urine. Phenyl pyruvate by decarboxylase, so CO2 is removed to form phenyl acetate, and phenyl acetate by conjugation with glutamine to form phenyl acetyl glutamine. So this is excreted in urine. So what does it give rise to? A mousy odor. Smells like a mouse. So this will be again asked in your MCQ. Viva. So phenylalanine undergoes transamination to form phenyl pyruvate. Phenyl pyruvate by reduction forms phenyl lactate, and by decarboxylation it forms phenyl acetate. Phenyl acetate undergoes conjugation with glutamine to form phenyl acetyl glutamine, which is excreted in urine to give you a mousy odor. So accumulation of phenylalanine leads to inhibit the enzyme 5-hydroxytryptophan decarboxylase, so there is defective serotonin formation. It also impairs melanin synthesis. So children of PKU tend to have hypopigmentation. They have light skin and light colored hair, which is hypopigmented. What are the clinical features? Mental retardation with an IQ of 25 to 50. Their agitation, hyperactivity, tremors, seizures, psychosis. They have eczema, failure to walk or talk, microcephaly, and failure to grow. These are all the clinical features what you see in PKU. So, blood phenylalanine is increased. Normally it is around 1 to 2 mg%. So, in case of PKU, it is around more than 15 to 65 mg%. The neurological presentation of PKU, initially you see that the children look like they are the normal neonates, and slowly the mother starts to notice the developmental delay, the milestones are delayed. Microcephaly, the head circumference is less compared to the normal children. There is mental retardation, there is autism, hyperactivity, seizures, movement disorders. So, phenyl lactic acid or phenyl acetic acid with conjugation with glutamine forms phenyl acetyl glutamine. I told you, gives rise to a mousy odor. That is your Tom and Jerry. Jerry is mouse. So, it is a musty odor or the mousy odor what you see in phenylketonuria. Increased phenylalanine can be demonstrated by paper chromatography. This is how we investigate phenylalanine. We do a simple chromatography and then we see the separation, isolation, identification of chromatography of this particular amino acid by paper chromatography. I think you all have done this in your practicals. Urine ferric chloride test, which is a screening test. The urine of the patient contains phenylketones about 500 to 3000 milligrams per day. This could be detected by adding just a drop of ferric chloride, and there is a transient blue-green color, which is positive test for phenylpyruvate. During my post-graduation, I did a project on this children, the special children, what we say, the mentally retarded children, where I tested on around 198 children, out of which I could get only one PKU. So, only one child was tested for this ferric chloride. The other test what we do is Guthrie's test. It is a rapid screening test. Certain strains of Bacillus subtilis which needs phenylalanine which is essential for their growth. This bacteria cannot grow in a culture medium which is devoid of phenylalanine. So, bacteria growth occurs when patient's blood containing phenylalanine. So, when the patient blood contains phenylalanine, you can see the growth of bacteria in this medium. Phenylalanine tolerance test. Administration of phenylalanine to a PKU patient should result. First of all, there is increased phenylalanine. So, you are administering again phenylalanine in these patients. So, you are going to see the prolonged elevation in the level of phenylalanine in blood. This is known as phenylalanine tolerance test. So, what is the treatment? So it is basically the diet. So diet containing low phenylalanine, so around 10 to 20 milligrams per kg body weight per day. So usually till 5 years, 5 to 6 years, they see that there is low phenylalanine diet. So in such case, in PKU, what happens? There is intake of phenylalanine is less. So what happens here? Tyrosine is an exception case where tyrosine becomes an essential amino acid. I repeat, in PKU, tyrosine is considered as an essential amino acid. So it must be provided in the diet. The name tyros is cheese. Okay? So it is from fowls, nuts, you get tyrosine. So only in this condition, that is in PKU, it becomes essential. So it has a sparing action on phenylalanine. Very important for MCQ. So these are all the foods which are high in phenylalanine foods. These are low in phenylalanine. Fish, beans, dairy products, eggs, meat, nuts, legumes, they all contain high protein foods, they all contain high phenylalanine. Low phenylalanine are present in all these vegetables, most of the fruits, sugars, breads, cookies, crackers, all these contain low protein food. This was regarding the phenylketonuria. Always when a short note is asked on any disease for that matter, please write the reaction, the enzyme which is deficit, and write the clinical features, what are the investigations, what tests we do, and then the treatment, the normal values, you should include all this. Coming to Alcaptonuria. So there is another one I forgot to mention, PKU. So there is maternal PKU. So this maternal PKU, suppose a patient is is a PKU patient, so she becomes pregnant. So what happens? The offsprings are also affected here. So there is increased blood phenylalanine level. The child presents with microcephaly, mental retardation, congenital heart abnormalities are seen in these newborns. Now coming to Alcaptonuria. This arises from the Arabic word alcaptone, means alkali. In Greek, to suck up oxygen greedily in alkali. So alcaptone means alkali. So in Greek, it is to suck up oxygen greedily in alkali. This is based on the observation that the urine becomes black on standing when it becomes alkaline. So keep it for some time. Once the child has passed urine, keep it. So standing means keep it aside for some time, then you see that it becomes black. So from top it goes on becoming black. Egyptian mummies in 2000 BC had pigmented cartilages due to Alcaptonuria. So Archibald Gerard in 1902 described Alcaptonuria. It is an inherited disorder, autosomal recessive. MCQ question, what is Gerard's tetrad? Name them. It constitutes Alcaptonuria, albinism, pentosuria, cystinuria. I repeat, tetrad. So there are 4 abnormalities or disorders, that is Alcaptonuria, albinism, pentosuria and cystinuria. In 1908, Gerard introduced the term inborn error of metabolism. The incidence here is 1 in 250,000 births, whereas PKU was 1 in 10,000 live births. The deficiency is homogentisic acid oxidase. It is otherwise known as homogentisic acid is not converted to mallyl acetoacetate. So here the phenylalanine metabolism. So the first step, you know, if this doesn't take place, it is PKU. Yeah. So in this case, so phenylalanine hydroxylase is present. So it is converted to tyrosine. Now this tyrosine by aminotransferase forms 4-hydroxyphenyl pyruvic acid, and 4-hydroxyphenyl pyruvic acid forms homogentisic acid. So this requires vitamin C, it requires oxygen, it also requires ferrous iron. So here it requires O2. So 4-hydroxyphenyl pyruvic acid in the presence of dioxygenase forms homogentisic acid. This is also known as 2,5-dihydroxyphenyl pyruvate or pyruvic acid. Phenyl acetic acid. Now, homogentisic acid is also known as 2,5-dihydroxyphenyl acetate or acetic acid. Homogentisic acid is converted to mallyl acetoacetate in the presence of dioxygenase. So this requires vitamin C, ferrous iron and oxygen. In case of Alcaptonuria, this enzyme, that is the homogentisic acid oxidase, is absent. So what happens? Mallyl acetoacetate is not formed. So what happens? Homogentisic acid is increased. So this is due to mutation or defect in the homogentisate dioxygenase, which causes lack of the enzyme homogentisate dioxygenase. This causes a buildup of homogentisic acid in the bones, cartilage and is excreted in urine. Homogentisate is an intermediate in the degradation pathway of the amino acid, that is phenylalanine and tyrosine. So this is an intermediate compound of phenylalanine or tyrosine metabolism. Para-hydroxyphenyl pyruvic acid to homogentisate, homogentisate to mallyl acetoacetate. So this enzyme is absent. So it is due to the enzyme deficiency homogentisate oxidase. So there is excretion of homogentisic acid in urine. So on standing, this turns black. Homogentisate acid by oxidation in the presence of polyphenol oxidase forms benzoquinone, and benzoquinone further is polymerized to form alcaptone bodies. I repeat, para-hydroxyphenyl pyruvate forms homogentisate. So this is from phenylalanine to tyrosine. Now homogentisate forms mallyl acetoacetate. in the presence of homogentisate oxidase, but since this enzyme is absent, so it cannot form mallyl acetoacetate. So this homogentisate is increased in urine, and it is also getting deposited in the tissues because homogentisic acid undergoes oxidation. So in the presence of polyphenol oxidase to form benzoquinone, benzoquinone is polymerized to form alkaptone bodies, and this gets deposited in the tissues. This is causing alcaptonuria. There is an experimental alcaptonuria. So here, as I told you, it requires ferrous iron, a chelating agent alpha-alpha dipyridyl, alpha-alpha dipyridyl, a chelating agent. This binds to this ferrous iron, so it prevents the enzyme and prevents the reaction, so thereby causing experimental alcaptonuria. What are the symptoms of alcaptonuria? They are dark stains, yes. The mother notice the nappy because it, instead of the hay colored or the yellow colored urine, what we say, so when the nappy turns black after the child passes urine, so that is the earliest sign of alcaptonuria. Symptoms become more noticeable after ages. There are dark spots in the sclera of the eyes. So in the sclera, there are black spots seen, alkaptone bodies. Then there is blue speckled discoloration of the skin, particularly around the sweat glands. So dark colored sweat or sweat stains are seen. The ear wax is also black. Kidney stones are present. Causes, it gets deposited in the intervertebral disc and the joint spaces, causing osteoarthritis, so especially of the hip and the knee joint, and it also causes heart problems. I came across, after my 20 plus years in biochemistry, just I think 3 months ago, I saw a patient, a child, pediatric. She was around 14 years of age. So when she was 8 years, she developed these symptoms. So the child went on telling her mom, saying she was passing black colored urine, and she had joint pains, she had the black discoloration, her IQ was less. So people thought that, you know, since she had low IQ, they thought she had some psychotic problems. So always they showed her to a psychiatrist, but it was not diagnosed. Then later, the medicine department in the hospital where I worked, they brought the urine sample to me. And when we saw that, the fresh urine was the normal urine, and when we had left it for some time, it turned black. So that was a very good case for us to see, and immediately we sent. The test was done in Hyderabad. So it was sent and it was confirmed, and the child from 8 years to 14 years, she was not diagnosed of alcaptonuria, but was on treatment for the psychiatry, thinking it was a psychosis. And she had joint pain, and she had fallen once or twice from the bus or something, or tripped. So they thought that it was due to the injury, but actually it was due to alcaptonuria, where the child developed pain in the joints, and there were the black discoloration in the pinna and sclera too. Here you can see clearly the urine, which is the freshly passed urine, freshly voided urine, and this urine on standing, which has turned black in color. You can see the discoloration, the blackish discoloration of the alcaptone bodies which are deposited in the connective tissues. So, you can see the black discoloration which are throughout the body, and you can see the discoloration in the sclera, the pinna, then it also gets deposited in the nasal bridge and intervertebral discs, and it is discoloration, the black spots are generalized. So, radiologically you can see the nose appears like a parrot beak appearance. Radiologically you see in Alcaptonuria the nose that appears like a parrot beak appearance. Ochronosis. On long-standing cases, so usually it is seen in the 3rd or the 4th decade, patient may develop backache, deposition of alcaptone bodies in intervertebral disc, as I was explaining to you. It is termed as, so when it is in urine, we say Alcaptonuria. So once it starts get deposited, so we call them as ochronosis. So the parrot beak appearance, radiologically what we see, and black pigmentation which is generalized and gets deposited in the connective tissue including joint cavities, causing arthritis or ochronosis. The mechanism is not clearly known, probably due to the oxidation of homogentisate by polyphenol oxidase forming benzoquinone acetate and further polymerizes, which binds to the connective tissue macromolecules, giving the black discolorations. How do you diagnose? So it is very clear cut, where you see on long standing the urine turns black, so which is a classic one. So increased blackening when exposed to sunlight and oxygen. On oxidation, urine starts to blacken from top layer in the test tube. Ferric chloride test is positive, so you add a drop of ferric chloride to it, so you see a transient blue-green color. Benedict's test is strongly positive. Yeah, this is very important now. So there will be a question usually asked in Viva. What are the reducing substances which, other than the carbohydrates or the sugars, which give Benedict's test positive? I repeat, Benedict's test is positive with the reducing substances. So name the reducing substance other than the sugars. So they are vitamin C, homogentisic acid, glutathione, uric acid, etc. Okay? They all give Benedict's test positive. So phenylalanine gives rise to, this is a flow chart. So here when this enzyme is deficit, phenylalanine hydroxylase, so it forms PKO. So when homogentisic acid oxidase is deficit, it gives rise to Alcaptonuria. So I will be discussing about albinism and tyrosinemia in my next class. So for today it is phenylpyruvate and Alcaptonuria. So just let us go through the odors. You have to remember the odors for MCQs. So MSUD has a maple syrup, the burnt sugar odor. Isovaleric acidemia, I will be discussing later. Sweaty feet. Cystinuria, it's a sulfur odor. Tyrosinemia type 1, boiled cabbage odor. Trimethylaminuria or dimethyl glycine dehydrogenase deficiency is old fishy odor. Multiple carboxylase deficiency, cat's urine. Phenylketonuria is a mousy odor, might be asked in your MCQs or in Viva. So the sweaty feet, maple syrup in MSUD, hypermethionemia or tyrosinemia, cabbage, boiled cabbage odor, multiple carboxylase deficiency, tomcats, urine odor, mousy or jerry, musty odor in phenylketonuria. So we need to do the screening test. So usually the blood is taken from the heel of the child, the neonate. Vitamin K injection is given, temperature is taken, umbilical cord. So the test now, amniocentesis is done. So even the newborn heel test is done. And now from umbilical cord, they take the blood, the cord blood, and do the test for all these inborn errors. So height, weight, head circumference should be measured because here it develops microcephaly. So antibiotic eye drops are given, immunization, all these should be done for a neonate so as to prevent or to lessen the complications. To conclude, the clinical outcome of children with inborn error of metabolism depends on multiple factors. So it is the type of the disorder, severity of the underlying metabolic defect, ability to make the diagnosis early. So early diagnosis is better. Availability of specific adequate treatment options, appropriate institutions for definitive therapeutic intervention. As I told you, to confirm Alcaptonuria, we have to send the test all the way to Hyderabad. So you can imagine. Depending on all these variables, some IEMs have relatively better prognosis than others. Many of these children are able to sustain longer lives, but many may be at risk for developing progressive neurological deficits. So the neurological deficits, the cause actually may be due to increased phenylalaninemia or which leads to defective transport of these other aromatic amino acids across the cell membrane, or imbalance in this amino acid distribution, which might cause all these toxicities. So learning disabilities, mental retardation will occur. It is therefore important for primary care providers to know how to recognize those conditions. As I told you, the mother is the first one to recognize whether regarding the black urine, the black nappy, or whether the milestones, regarding the milestones, she will be comparing her child with others of the same age group. So manage them in the interim while awaiting definitive diagnosis, and refer them to appropriate metabolic specialist for collaborative management of these patients. So early treatment and correct treatment is required to prevent the complications. Thank you very much.